Hi, this is Vic Gatto. Welcome to the Health Storm. Today I have John Mehall here. He's a doctor of cardiac surgery. He's been doing heart surgery for 25 years, but he also has moved up into healthcare leadership, hospital leadership, nationwide practice group, and then he started 7 different businesses. Great guy, really good healthcare mind. We talk about COVID-19 and the impact on the industry. Please watch it. I think you'll really enjoy the show. Again, John Mehall, cardiac surgeon. Thanks. Excited to have John Mehall here. He's a cardiac surgeon, but he also is an entrepreneur and investor, lots of experience in the practice of medicine as well as the business of medicine. John, thanks for coming on. Really appreciate doing the Health Storm.
Yeah, my pleasure, Vic. Thanks for the opportunity.
So tell the audience a little bit about your background. It's a wide-ranging, lots of interesting things you've done in the last several years.
Sure, thanks. So I have been a practicing cardiac surgeon for over 20 years. And as I was doing that, I would continually see different opportunities mostly in the cardiovascular space to either provide services to hospitals, provide services to other practices. And as I would take on evolving leadership roles, I first ran a hospital and then a regional health system and then co-chaired a national service line, all in the cardiovascular space. I would see these opportunities and then I started to operationalize them. And so I ended up starting a number of different businesses in the outsourced cardiovascular services, in practice management services for other practices, and then also ultimately in staffing, where I built a pretty large cardiovascular focused staffing business. And as I would successfully exit those, I would roll the energy and resources into new endeavors. And still actively involved in the staffing business now.
Yeah, so it's pretty interesting. I mean, one of the things that I'm really focused on is entrepreneurs or business leaders seeing a problem that's in their everyday life. Like maybe potentially as a cardiac surgeon, you saw a need for X, and often those people will look around and there's not a good solution, and so they just kind of create it, or they work to pull in others to create it. Is that fair?
Yeah.
Is that what you've seen?
Oh yeah. Necessity is the mother of invention.
Right.
And so in my case, I started a private practice and we grew to multiple sites and had about 9 surgeons and a host of mid-level providers and other things. And I was trying to run it, in the evening from my kitchen table. And it was just, not a great way to run a, high gross revenue business. And so I went to look for a resource to help me do that, and I couldn't find one. So I ended up hiring or helping somebody. I brought somebody into market and helped them get a business started to provide that service. And then that business now has kind of taken a life of its own, and he runs it with multiple other clients. And but it was born out of necessity. And that's very similar to how I got into other businesses as well.
Yeah, I mean, one of the things that my investment platform has had success in is what I call a demand pull on innovation, right? So the customers or the market is demanding this problem be solved. That's very different than a kind of entrepreneur building something that's really cool and then trying to push it out there.
Yeah, that's right. I mean, in the case that you're describing, and in my case, the demand and the need was there, and we found a way to service it as opposed to trying to anticipate what it might be.
Yeah. So give people perspective. You, for Catholic Health Initiatives, you run a national service line. Is that the right way to say it?
Yeah. So Catholic Health Initiatives, prior to merging with Dignity to form Common Spirit Health, has had a national cardiovascular service line for quite some time. And I've been involved in that for, I don't know, probably 5 or 7 years. And eventually was helping to lead that. And then as we merged with Dignity, we merged that service line. And in fact, we just had a call yesterday. And now we have roughly 30 some odd heart surgery programs with almost 90 surgeons across the country. And
probably one of the bigger practice groups around the country, I would think.
Yeah, interestingly, it's really more of a federation because each of those is operating independently at their different locale, and there's two systems that have been rolled together.
Right.
But from a volume of work that's being done, absolutely, probably the largest in the country, if I had to guess. HCA is probably really close too, but
Yeah.
we're doing about 25,000 open heart operations a year across the whole system.
Yeah, and I understand everything in medicine is sort of a practice, and each physician and then each practice and each hospital and then across the service line is a federation. But is it right to say you share best practices and trade information and try to learn from each other?
Yeah, and we absolutely, that's exactly the whole goal of the service line, is to identify high performers, figure out what they're doing well, and then try and reproduce that at scale across the system. And we have a pretty organized way of doing that. We have what's called a shared learning program, and we have a group of folks that will travel to a high performing site and a low performing site and bring surgeons from each of those sites to the other and try and disseminate that information. We have a open flow of information in terms of outcomes and results. And so, it's we open the kimono,
so you can
and see who's doing well. And
everyone can see each other's outcome results and hopefully learn and lift all the boats.
Right, and there is some inherent competition in there, if you want to call it that.
Yeah.
There's a great case study.
Yeah, several hundred cardiac surgeons are going to be a competitive group a little bit.
Yeah, two is a competitive group.
Right.
They're inherently competitive by nature, but
Yeah.
for sure, yeah.
Yeah. Okay, and then you've done 6 or 7 startups and invested in a bunch more. Is that right?
That's correct. So I've started 7 of my own businesses. I've invested with some folks and helped them in multiple other ventures. All of my ventures are all in a relatively focused area, in the sense that I kind of stuck to what I knew. I never went way out of the limb in a new area to do something that I didn't know anything about. And I think that keeping it all close together with commonalities has helped a lot.
And is it all around the cardiovascular system?
Mostly, yeah. It's all around either the practice of medicine, outsourced services to hospitals, or staffing.
Yeah. Okay. So that was going to be my follow-up question is, doing open heart surgery, leading a practice line, inventing new startups. How do you balance all of these things in your day?
Sure. With some difficulty a little bit, but I think I continue to practice because I think it's essential to understand what's going on the front line and keep your finger on the pulse, and also to stay relevant.
Yeah, but it changes pretty quickly. So if you don't operate for some number of months, you would get not obsolete, but you would lose the cutting edge understanding.
Yeah, I think that's right. And then I think the keys to allow me to do that have been to do things that are somewhat related, and so I'm not trying to develop totally different areas of knowledge, and then also have built a really good team. I've had a group of people that have been with me for a decade or more, and they're high functioning and super loyal, and we work really well together, and they've helped me do a number of these different things, and have kind of just rolled with me through all those adventures.
Mm-hmm. Yeah, good. Okay, well, as you know, this video series is called The Health Storm. Last fall, around Thanksgiving or so, I was starting to see a bunch of emerging trends and concerned that a storm or a pretty big disruption was going to come to the industry in a 3 to 5 year time horizon. Mm-hmm. And started this effort to write about it and pull in experts like yourself about it. And then, of course, COVID-19 hit, and I feel like everything has gotten accelerated.
For sure.
It's maybe a different flavor, but a lot of those trends are sort of accentuated or growing quickly. So I want to just get your take on these trends. So the first one is the rise of the consumer. Consumers are beginning to try to take more ownership, they have more financial responsibility, but they also want to gather data and be involved in their own care, much more so than in years past. Do you see that as a trend out there where you are?
Yeah, I think that's absolutely true. I think I see that in a couple different ways. One is consumers are bearing more of the cost of their care, and so therefore they're more vested in what it is going to cost and where they're going to get it, and to some degree, I think they're more invested in the outcome if they're going to have additional costs if they don't have a good outcome.
Right.
And so, 20 years ago or even 10 years ago in practice, we would never have anybody come and ask for an out-of-pocket estimate. And I would say that the majority, if not 2/3 or 3/4 of the patients now ask for an out-of-pocket estimate before they sign up to have a big expensive operation.
Right.
And so there's been a really big shift in that. I think the other thing driving the consumerism is there's been democratization of medical knowledge. The internet, for better or worse, has a huge amount of information out there, and there's great information out there, there's bad information out there, but there's so much information out there that there is some degree of empowerment of non-medical professionals, whereas used to be all of that information was between one person's ears and you had to go to the oracle to hear what they had to say, and there was no way to learn about it on your own. And I think that has empowered consumers to feel more comfortable making some of those choices. And I think the convenience thing is another big piece of it. Consumers really want convenience. Patients want convenience. I've seen that a lot. We did very little telehealth prior to COVID, and since in the last 6 weeks, we've done a huge amount of telehealth, and the patients love it because they can sit and wait to talk with me on their own couch or in the kitchen or wherever.
Yeah. Another trend is the sort of the technology platforms and data systems are increasing significantly.
Mm-hmm.
And I think that was going on before COVID, but as you know, in healthcare, we have a lot of regulatory and reimbursement infrastructure that needs to catch up to the capabilities in technology. And what I think COVID has done is, it's like wartime decisions. So CMS has now they're reimbursing you for telemedicine calls. And also there's no state line licensure issues anymore. And so that really has opened up the ability for physicians to treat patients in the convenient way they want. I think you can answer, but I think it's pretty effective. And you don't have to worry about someone being just over the state line who has been driving into you, but now no longer does.
That's exactly right. And I don't think you can overstate that. And I think it's probably been underappreciated, is that one of the major obstacles to driving a lot of these consumer choices that consumers really want and are technologically very feasible and could easily be put in place is, or has been rather, this regulatory gridlock. And it's really been a lot of resistance by entrenched incumbent players in the market that don't want to see consumerism.
Right.
And so, people have been asking for years for a national license or removal of all these state barriers. But, that's a revenue source for states. They are employing people, et cetera, et cetera. Hospitals don't want to lose control of some of these services that could be done much less expensively or more conveniently outside the hospital. And so the incumbents have been, very motivated to perpetuate the status quo. And I think it was ultimately going to take a crisis like this one to get some of those barriers to fall. And I really hope that we don't go back to that now that we've broken.
Yeah, I don't see that I think it's going to be hard to put it back in the bottle. I mean, I understand why people are protecting their established businesses. When I was thinking last fall about this coming storm, that's why I had a 3-5 year time horizon, because it's going to take a while to sort of crack those walls down. But once, and unfortunately, I wish the storm didn't come that came, which, cost a lot of lives, and it's, going to be really hard health-wise and hard economically. But the benefit of it is these kind of traditionally strong, almost lobbying or political groups are falling away because we need to get solutions out there.
Yeah, that's right. That's right. The human need and the economic need trumped other people's political needs, and that's what ultimately needed to happen. Like you said, unfortunately, there is a human and an economic price for that. But maybe the positive will be that we've broken down some barriers that we otherwise couldn't have.
Right. Yeah, and then I see market entry from new players that are not traditional health companies or brands jumping in and whether you say Google, Apple, Walmart, Amazon, there's lots of names you could throw out. I think they all have very strong balance sheets. They understand consumerism. They understand data and technology. at a level of understanding that most health systems and insurance companies are not as facile with. And so I see that being a sort of a trend that's going to accelerate again.
Yeah, I think that's right. And I think part of that has been we are not focusing on the widget anymore, and we're starting to focus on the big picture. And so if you're a Walmart or a big employer and you're going to look at the global cost of caring for your employee, and that employee is likely to be there for some period of time, then you're going to be more incentivized to find that person low cost, high quality care, as opposed to find the cheapest thing you have, and then you're going to have a more expensive problem later. And I think really a lot of people hadn't looked at that for years. It was just simply, let me find the cheapest one I can. And now people are starting to look at that. I mean, I think the mobility of the workforce is a little bit of challenge against that, as people do tend to change jobs more often. But I think even in that setting, employers are starting to realize it's more economical to focus on wellness and health prevention and some of these other things than it is to have expensive back surgery or other things later down the road.
Yeah, so I had the head of health for General Motors on yesterday. I don't think it's live yet, but and she said something really interesting related to that, which is yes, there's a lifetime in the employee, and you know, how long are they going to be here? That's been the traditional viewpoint. Mm-hmm. Her point of view is shifting, where she thinks, I don't think we have evidence for it, but it seems like if you had underlying kind of chronic disease coming into COVID, your cost and the ability for you to work and the expense and honestly the health danger of this new virus is dramatically worse. So she's thinking about it almost like a preparing for various crises that might happen, and also to make her workforce more healthy and more productive and better all around. It's worth it to invest in preventative or, you know, managing chronic disease better. Does that make sense to you? I mean, in cardiovascular is one of the key chronic diseases, obviously.
Yeah, for sure. I think the focus on chronic disease management, and we're realizing now the massive cost of that, both in dollars and also in complications and new care and the toll that the patients carry. And that's a huge realization, where before we were very focused on, you have this problem, we'll fix this problem, and then put you back out where you were. Right. And we're realizing now that that's not a good approach for the patient or the system, and we're gonna be much more cost efficient, and patients are gonna be healthier and as workers more productive if we can really effectively manage some of these chronic disease states. And you're right, they do make those patients more susceptible to other problems down the road.
Yeah, so let's shift to the timing of things. So, you know, we're in the middle of COVID-19 right now. I've been trying to think about how does this roll out over the next 2, 4, 8, 12, 24 months. And the framework that I've been trying to understand is, I think we're in a crisis right now where, you know, people are dying. It's super scary. I'm here in my guest room, you know, in quarantine. And there's a crisis where we're just trying to manage the outbreak. But then I'm thinking about recovery and what I'm calling a new normal. We don't come back to, you know, where we were last year, but there is a normalcy that's probably upgraded or different because we've been through this crisis. Tell me about your thoughts about when do we enter recovery? What does that look like? And then how long is it till we get to some sort of new normal?
Yeah, I think you're right. We're in the throes of the crisis now, although it would appear that we're going to be able to weather that storm maybe better than some thought. And I think you're exactly right that I think this is going to permanently change what our definition of normal is. You know, very similar to the way that 9/11 changed a lot of things permanently after that. I think with respect to public health and hygiene and other things, some things are going to permanently change. And when I think about the, you know, recovery, I really think that as the transition and definition of the new normal, and how long it takes for people to figure out what they're comfortable doing, what they're not comfortable doing, and which behaviors they feel like they can go about and return to safely. I think that's going to be the process, and it'll probably take every bit of 6 to 12 months to really establish something that resembles a new normal. I think, you know, some behaviors may go away permanently. I mean, the idea of packing 100,000 people into a stadium for a college football game or a Super Bowl or something, some people may be comfortable with that. Some people will never be comfortable with that again. And the level of hygiene that we're going to expect at an airport or a restaurant or on an airplane or whatever the case may be, our expectation is now much, much higher. And I think the use of masks is going to be much more ubiquitous, and people aren't going to think twice about it. So I think those things are going to get woven into the fabric of new normal.
Yeah, and one of the things that I am frustrated about, but also appreciate the benefit of, is our country is it's a federation of all these different states and local cities, and every city probably, or every region, is going to run their own test of like what does their citizens see, what do they want to entertain as the new normal, and then over 12 months, it might be 24 or 36 months, they'll begin to become a new US normal. I think it's going to look different in Texas than in Florida, than in Boston, than in California.
Yeah, for sure. I mean, there's no question it's going to look different. It's going to look different because each of those areas has their own subculture, their own values, identity, and they're each going to have been affected by this in a different way. I mean, the people in New York have been profoundly more affected than people maybe in the Great Plains or something where it hasn't been as prevalent.
Yeah.
So I think you're absolutely right. That's going to be the case. And I think that also speaks to, the traditional American individualism is reflected in that federated state, segmented approach. And when you think about public health, a country such as ours, which has a strong individual character and spirit, and I love that, but it also means that people are maybe less willing to make sacrifices around public health, more wanting to do their own thing. I mean, there's been plenty of protests about the government overstepping their bounds to put some of these restrictions in place. And so when I think about that from a public health standpoint, I think we may be as a country less able to do some drastic public health things that might restrict individual freedoms. But I think in compensation for that, we're going to maybe work harder at being prepared to have a good response if something does happen, because we may be less able to prevent it on the front end.
Yeah, so I think that makes sense to me, that we're not going to turn into another type state in Asia or in Europe where they have much more of a follow the leader approach. I mean, our citizens are not going to necessarily do that. But I do think that people understand, the zeitgeist in general understands that health is foundational to life. Like if you don't have health, you don't have schools, you don't have business, you don't have tax income, you don't have anything. And so there's going to be a need to invest money and invest in systems and stockpile resources. And I think I would extend it, I hope it extends to trying to keep people out of the chronic, really sick categories and provide some basic care around diet, exercise, heart disease, diabetes. Because if we don't do that, then when a crisis hits, it's much harder to deal with because you have people that are much more susceptible.
Yeah, I think that's exactly right. And I think the willingness to spend money on and time and give employees time to pursue health and wellness is going to be much lower. People are going to focus on those things and address them with a new level of vigor that they haven't before because of the realization, as you said, that health is foundational. And I think the other big change that I really see is that we have come to realize that we don't have good supply chain and we don't have redundancy in our supply chain, and that there are some key things that are only made one place, and unfortunately some of those things are only made in countries in other sides of the world. And so the analogy is that the U.S. military would have never outsourced all of their ammunition production to China, but we outsourced all of our medication production to China. And there's one factory, it's actually there in Tennessee, that makes all the morphine. And there was 2 years ago a strike there, and there was a huge shortage of morphine. And when the hurricane hit Puerto Rico, that was the only IV bag manufacturing plant in the world.
Yeah.
And so these kind of things, I think, have been brought to light by this, that we need to have, multiple sources of key supplies. We need to have reasonable stockpiles of key supplies. And I think people are going to be more willing to spend to have that, because we went to this model that we have now because it's cheap. And so
I feel like we optimize supply chains for efficiency and cost reduction. Right. And that meant massive scale and centralizing production in the cheapest location. Mm-hmm. And we need to dial that back to more balance between resiliency. And of course, we want cost to be a factor, but we need to have the supply chain be resilient to a natural disaster or a pandemic or a war or a strike. All these things can be solved with a little more resiliency kind of built in the model, but that will increase the price slightly. And the benefit that will be, you'll be less susceptible to outages.
That's exactly right. Yeah, but I think that's a price that people weren't necessarily willing to pay before, and now they see the value in it.
Yeah, I mean, it's kind of sad, but until we went through this crisis, people couldn't appreciate why the resiliency was going to be important.
Mm-hmm. Yeah. That's
I want you to talk through the changes to the relationship with your primary care doc. We talked in the pre-call about just how the relationship I have with the healthcare system has evolved in the last 50, 75 years. Talk through how things changed from, the 30s and 40s, where you had one doc, to now, which is much more episodic based.
Yeah, I think the most expensive part of medicine, everybody gets very wound up about the new technology and expensive machines, but really at the end of the day, the most expensive part of medicine is the human capital and the providers and the expertise that they have and getting them to that point. And historically, we've not really been able to use that human capital as efficiently as we might have. If you think about, if you're running an airline, you've got pilots who are highly skilled, trained people, and they move them around for maximal efficiency, and passengers getting on the plane, they don't necessarily know who the pilot is, but they just trust that they're good and they're going to get them there safely. And we've never done that with physicians or healthcare providers.
I'm not calling the pilot to ask if the plane's going to be on time. They've delegated that to other people. Yeah.
That's right. And I think in healthcare, because we had this holdover legacy relationship where patients would have a very long longitudinal relationship with one individual. And if you go back, like you're saying, to the 30s, you probably had one doctor that maybe delivered you as a baby. And if he was still alive, sat by your bedside as you were dying. And so you had a very tight bond with a certain individual, and therefore all of your care went through that individual.
Yeah, and your medical record was not electronic; it was in his head. Yeah. And he had a few enough patients that he kept up with them, and he knew the family and the community, and it was sort of integrated in the whole system.
That's right. And that's also where you got your convenience, and you didn't pay for any of it, so you were agnostic to cost. And so it was just a very different model. But what has prevented us from getting some of that convenience and cost and other stuff is that I think people have held on to conceptually that kind of a relationship. And that has slowly been broken down over the last 50 years as people and medicine became more specialized. When all of a sudden you had a doctor for every organ and a surgeon for every kind of procedure, then patients came to realize that, I really don't want one person doing my neurosurgery and taking care of my allergies. And obviously that doesn't happen because it doesn't make sense. But as that has broken down, that tight relationship between a patient and one doctor has shifted. And now that relationship is more with, I'm going to find the best person for the job who is convenient and cost efficient. And I think that's been a fundamental shift that had to happen, so that now a patient's decision-making is much more, as we were saying earlier, consumer-driven. Your decision-making around finding a good spine surgeon or a heart surgeon or a whatever kind of specialist you may need is now driven by, I'm going to find someone who has the best skill or knowledge base, who's convenient, who has reasonable costs, et cetera, more so than I'm going to stick with Dr. Jones because I've been with him the whole time.
Yeah, and then there's, of course, benefits to specialization, but we lose the longitudinal context, right? Like you don't have that long term, and maybe electronic medical records could get there eventually. Right now, they're fairly siloed, and they don't really provide that. And so,
Yeah, I
is there
think
a way to balance those two?
I think the longitudinal memory of one person knowing it all is lost and has been for a long time.
Right.
And I think even if you think about people who, even if you think about patients' primary care now, very rarely do they have one person because that group got bought, the doctor moved, et cetera. And so that longitudinal relationship, even at the primary care level, is very hard to find. And instead, as medical information has become more democratized, the patients are holding on to that information. They have portals and other sources to get their information out of the health system. And there's an electronic record within the health system, and then patients are keeping a lot of the records on their own now. And so now that bond has been broken and patients are very comfortable getting episodic care, and they're starting to get more comfortable getting care from maybe not a doctor, but from a nurse practitioner or a physician assistant or some other provider who's working at top of scale, that's really allowing us to seek care in the most efficient way to, if you're on the hospital or provider side, to allocate resources in the most efficient way, and for each person to work at top of scale at the top of their license. And I think that's going to drive tremendous efficiency.
So that makes sense to me. Is there an opportunity to build a brand and a data understanding of the patient? So like I've had the same credit card for, 25 years. Mm-hmm. And that firm has, my spending patterns for 25 years.
Yeah.
They do a very good job understanding when my credit card gets stolen, just like everyone's credit card gets stolen from time to time. They know pretty quickly because it's out of my pattern behavior. Do you think that there's an analogy where health systems could more create a brand that I would be associated with and trust, even if the individual people might come and go, or be used for different particular top of license skills?
Yeah, I think that's already happening, and it has happened for a number of years now. If somebody had a problem and they went to the Cleveland Clinic or the Mayo Clinic, they probably don't know necessarily what doctor they're going to see, but they're comfortable going because of the brand. Yeah. Or MD Anderson, or right. Any number of those kind of high-level institutions. And so I think that is definitely happening. And I think at the same time, to back to your comment about the history and the medical record, people are gathering that huge amount of health data so that they understand what's going on with the patient and if something is out of line with their normal stuff. And now with those kind of massive amounts of data being built together and then being able to be analyzed, we're able to start to anticipate that, hey, maybe this patient is going to have diabetes, or maybe this patient's going to have another chronic condition, or maybe they have it already and they just hasn't been identified, and start to preemptively get them involved in care to either address it or treat it or prevent it. And I think that's the kind of data that employers are starting to amass on a huge scale and be able to analyze. And I think it's going to improve the health of their workforce.
Yeah. Okay, interesting. So talk to me about the health systems, really the hospitals, but then the hospitals and clinics and surgery centers and diagnostic centers that many brands, including the one you work with, have aggregated into a whole system that I feel like they are ground zero for the COVID-19 fight. Like that is the front lines. We're relying on those EDs and those ICUs to kind of triage and then care for the people that are sick. And yet at the same time, that very service is not profitable, and it's weakening the balance sheet and the strength of these companies, and some of them are nonprofit, but these entities. And so I want your impression of, are these health systems sort of the center of the value chain and the most important piece, or are they going to be subject to consolidation and other entities kind of picking off profitable areas and kind of have bullseye on their back? Or is it both? I can't figure out like how to think about the health systems over the next 6, 12, 24 months.
Well, I think what you're highlighting is kind of what I call the hospital conundrum. And I think the COVID crisis has really laid that bare. And in my way of thinking about it, is half of what hospitals do is very profitable, and half of what they do is at best break even, or probably money losers.
Yeah.
And historically, hospitals provided both sets of services. They served the whole community, and they were somehow able to make the finances work so they could stay afloat. Usually on a pretty thin margin. And with the COVID crisis hitting, all of a sudden, hospitals have stopped the services that produce probably
all the profitable services are stopped, or maybe even not allowed to be done right now.
That's right. So profitable services, which were probably, an operating room is probably 75% of a hospital's, engine revenue generator comes from the operating room. So all of a sudden that is sitting there, crickets, with nobody doing anything. And likely, I think, not for a while. I mean, patients are really reluctant to come back into the hospital. So I think even when we're resume, quote unquote, elective procedures, I think the number of procedures they're going to actually do is going to be very small. So their revenue plummeted. Their expenses went up dramatically with both COVID patients who may or may not have resources, and inherently, even if they're reimbursed at a federal level, are probably money losers, and their expenses for PPE and employment programs and maybe childcare, and they're doing a lot of things to try and help their employees, have gone up through the roof. And so that's going to really put all the health systems and hospitals and the private practice physicians that are left in a very difficult financial position going forward. And I think it's going to force them to make some decisions that they've kicked down the road for decades, really, of should we be providing this service? Should we not be providing this service? And it's gonna hit some communities hard, as some facilities will stop providing some services, or maybe become insolvent and close altogether. And I think that's ultimately going to drive some of this consolidation and regionalization that you're referring to. The hospital has been all things to all people for a long, long time, and they want to provide super specialized care, spine surgery, heart surgery, right, orthopedics, and high levels of community access for trauma and community access for cancer programs. And those things all come at a significant cost. And depending on the demographics, as you get into more suburban and rural areas, you may not have the patient populations to support those things, but the community demand has always been, you have to do these things. And so they've tried to address the community's desire.
Right.
And I don't think they'll be able to do
that. It's going to be, I think it's similar to kind of when Main Street retail had troubles and the big box stores came in and sort of were bigger brands and could offer sort of everything under one roof. It's not exactly the same, but I think there's going to be health systems that expand and offer kind of best practice spine surgery, best practice cancer surgery nationwide, but centralized into 2 or 3 locations and pull from the entire country. And the local kind of community hospitals are not going to be able to keep doing that work. They're not going to have the patient population to do it.
Yeah, I think that's exactly right. I think that community hospitals' ability to continue doing that kind of work when the human capital is high, the resources needed to do it are high, the volume is low, the quality may be high or may be low because of volume. Right. And a large regional player can reach out to all those communities and then drive those patients into one center. And I think especially now that a lot of that outreach can be done by telehealth. And I think when I think about that, I think the country's kind of in maybe not 2 halves, but the eastern half of the country is relatively densely populated. The middle portion of the plains and mountain states is very sparsely populated, and except for a few large centers, you really wouldn't have a lot of these high-level services, except for maybe one place in each state. And I live in Colorado, and so it's very, very much like that, where we have a majority of our patients live in about a 150-mile stretch, and then several million patients live scattered all over the state. And so we do a lot of outreach to those centers that are all over the state and in adjacent states to do telehealth or other remote clinics to capture those patients. And then we bring them back to 2 centers where we do all the procedures. And that cohorts a lot of patients into those centers with higher volume and higher quality. And it brings that access to that care to all those patients who otherwise would be either seeking it in a community hospital or have no access at all.
Yeah, and you may even have outposts where there's clinic-like facilities, and there's a med tech or a nurse RN helping the patient get their labs done, but they see you over a teleconference thing.
Yeah, that's
I'm
exactly
not
what
sure
we
that's
do.
exactly right design, but there's lots of ways you could design this that would be more efficient to take advantage of the resources and get the care out to people that are needed.
Yeah, I mean that's exactly the model, Vic. And in our specialty of cardiac surgery, we're fed generally by cardiologists, and cardiologists are generally fed by a primary care base. And so we do outreach at centers where they have a small hospital. They have a few cardiologists. Most of them will have a cardiac catheterization lab, but they won't have any surgery or surgical resources. And then so we're able to keep a lot of those services in that community: ancillary testing, the actual visits, seeing the patient, their follow-up, et cetera. And then they really just come for one procedure to a major metro center.
Right. Yeah. Okay. So let's shift to, I mean, you do startups, you've done a lot of investing. Where do you think, my audience is sort of a mix of health industry and investors, but to the investors, what do you think is the best opportunity? Where are the areas that should be ripe for investment over the next little while, next 6 months, next 12 months?
I think the areas that I've traditionally focused in is if somebody has a better mousetrap, and that could be anything from a medical device to a way of solving a problem. Those are always winners. And I think with the COVID thing accelerating a lot of the storm, that consumerism and consumer access and convenience things are still going to be big. And where I'm mostly focused is really around staffing, because hospitals are going to continue to need people. Their budgets have been decimated. And so if you're running a hospital, 70% of your cost is in the people. And so we're going to have to find a way to provide those people on a more economic basis. And I think what we were talking about earlier about the severing of this longitudinal relationship between doctor and patient's acceptance of more episodic care, where they're going to show up and get on the plane, but they don't know the pilot. That's going to allow hospitals to use their human capital more efficiently. And I think they're going to start to think about, do we need to provide this service at this facility 24/7, 365, or could we have that service there for 3 days a month or 1 week a month, or could we provide a clinic there?
When you aggregate the volume on those 3 days, and then it's effective. Yeah.
That's right. And I think that's an area where there's been a lot of legacy barriers. There's a huge number of hospitals around the country that maintain neurosurgery, orthopedic surgery, cardiac surgery, simply so they can maintain a trauma status designation.
Yeah, I mean, right. That's a reimbursement policy thing that needs to be changed. Yeah.
That's exactly right. And so, we did a lot of work in the staffing business, putting specialist surgeons at facilities that had essentially no volume, simply to maintain their trauma designation, because then they got paid a higher DRG for every service they provided.
Right.
And it made for a good staffing business, but it's really very inefficient for the hospital.
Yeah. What are your thoughts about I think it's a transition of the health workers from the community hospitals to the big centers, because as we're talking about, some of those community hospitals are not going to need as many nurses and med techs and infrastructure. They'll need some, but I think there's an opportunity in staffing to help with those transitions. Over the next 5 years, there's going to be a ton of change in where people work in healthcare, and there's a need for people to help navigate.
Yeah, I think that's right. I think there's going to be a lot of shift of where people work, and I also see the explosion of advanced practitioner providers, whether they're nurse practitioners or PAs or other, physician enablers who, frankly, they could provide a huge amount of the care that physicians have traditionally provided, and they're very good at it. They're very knowledgeable. As they work in a narrow spectrum, their knowledge base gets even deeper, and they get more capable. And they're less expensive resources for hospitals. And so as patients get more comfortable with that, and as providers get more comfortable with that, I think that's going to really grow a lot. And that will allow the physicians who have unique skills to, practice at top of scale doing that one unique thing.
Yeah. Excellent. Okay, excellent. Well, and then the last thing, you've been doing this for in practicing healthcare or the business of healthcare for 25 years, 20 to 30 years. What do you wish you knew when you started that you know now?
Probably a lot. I think the one thing that I maybe wish I had done is, I've done a lot of different things and I've learned a lot, and I'm probably the product of all those experiences. But sometimes it's better to have singular focus and focus on one thing and try and move the ball 1,000 miles in one direction instead of 1 mile in 1,000 directions. Yeah. And sometimes that's hard to do when you have a lot of interest and they're all competing. But I've definitely learned that you can make more of an impact doing that.
Yeah. So focus. You'd tell your younger self to focus in a smaller set of areas and try to impact. Is that right?
Yeah, I think that, and I think also just the absolute essential fact that you have to be passionate in what you're doing. You have to understand the why of why you're doing it and what your mission is, and you have to be able to communicate that very clearly so that everybody on the team knows what the mission is and it has line of sight between what their role is and the goal you're trying to get to.
Mm-hmm. Right. Well, thanks, John. I really enjoyed this. Appreciate you taking time in this busy time to talk through it with me.
Yeah, no, my pleasure, Vic. It was a great conversation, and I appreciate the opportunity.
Yeah. All right. Have a good day. Appreciate it.
You too. Be well.